Okay, what's up, guys? Welcome back. This is going to be the neurology system practice questions. So we'll go ahead and jump right into it, starting out with GCS, the Glasgow Coma Scale. So a few example questions here, and then we'll go through the answers. So question one is, a patient comes in and his eyes are spontaneously open. He is using inappropriate words, but is still comprehensible, and he has a flexion withdrawal to pain. What's his GCS score? So again, inappropriate words, still comprehensible. He has a flexion withdrawal to pain, but his eyes are spontaneously open. So that's question one. Question two, a patient comes in and his eyes are open only to pain. He is incomprehensibly babbling, as you cannot really make out any words he's saying, and you find his arms and legs flabby. What's his GCS? And the third question for GCS, a patient comes in with abnormally flexed arms, a confused orientation, but still comprehensible, and not using inappropriate words. However, he can only keep his eyes open to speech when you command him on exam. What is his GCS? So we have the GCS here. EVM is how I remember it. E for eyes, V for verbal, M for motor, and there's 4 for eyes, there's 5 for verbal, and there's 6 for motor. So the first one is 11. His GCS score was 11. His second one is 5. And the third question, GCS score is 11. And as a correction here, decerebrate, if they give you decerebrate as a word, that's actually extension, not decorticate. So abnormal flexion is decorticate. So bringing your arms to your core, think of that. Decorticate, bringing your arms to your core, that's that abnormal flexion. Okay, next one. What is the Cushing's triad in TBI? So what is the Cushing's triad in a traumatic brain injury? That's going to be hypertension, bradycardia, and abnormal respiration. So think about is the opposite of like a septic shock where it's hypotensive and tachycardic. This is hypertensive and bradycardic with abnormal respirations. And that's in the Cushing's triad in a TBI. Next question is, what is the mainstay of treatment for a concussion? What imaging is required in a concussion? And what are the parameters for return after a concussion? So what's the treatment, what imaging, and what are the parameters for return? So the treatment is cognitive and physical rest. So you don't want them on their computer and doing all kinds of stuff like that. You want to observe them for the first 24 hours. And it can be family that observes them as well. And no imaging is also required for them. So the imaging required is no imaging. No imaging is required unless it's a mechanism where you think a non-contrast CT of the head would be best if it was severe, but no imaging is required. The parameters to return and make sure their memory is back, as well as their cognitive functioning as well. Okay, so next one is explain upper versus lower motor neurons. So explain upper versus lower motor neurons. What are some diseases of this? What are some examples of each and how that works and how that happens? So upper versus lower motor neuron lesions. So upper lesions are going to lead to spastic contraction, as we no longer have the inhibitory effects of the CNS, which is the upper motor neuron, to regulate the lower level reflex arcs. So the reflexes are just going to fire uncontrollably. You could see some positive Babinski signs, spastic paralysis, clonus, increased DTRs, and this might be from things like stroke, multiple sclerosis, cerebral palsy, or TBI. So without the upper motor neuron inhibitory process of the CNS, those reflex arcs in those lower motor neurons are not going to have anybody to taper them down. They're just going to be contracting. So that's why you're going to get those spastic symptoms. On the other hand, lower motor neuron, we can deduce from this that if we have lesions in the lower motor neuron, the upper is the only thing working, then we'll no longer have the reflex arcs and we'll just have the inhibitory effects of the CNS on those arcs. So it will be flaccid and flabby, and it also decreased DTR, fasciculations, flaccid paralysis, areflexia. These are all examples of ascending paralysis like a GBS, botulism, polio, Bell's palsy. So remember, cranial nerves are technically lower motor neurons as well. So that's why we see in Bell's palsy, the palsy of the face where we can't contract the facial nerve. So that's a lower motor neuron in line with what we're talking about here. And so next question will be, state all the 12 cranial nerves. State all the 12 cranial nerves. What cranial nerves are involved in eyelid movement? What cranial nerves are involved in eyelid movement? Meaning what cranial nerve opens the eye and what cranial nerve closes the eye. What cranial nerves are involved in the pupillary reflex? And what cranial nerves are involved in the corneal reflex? So cranial nerves, one is going to be olfactory, that's going to be smell. You want to have them identify something that they can smell. Can't really test that often though. 2 is the optic nerve, so that's going to take light in, of course visual acuity. 3 is the oculomotor. 4 is the trochlear nerve. 5 is the trigeminal nerve. 6 is the abducens, which abducts the eye. 7 is the facial nerve. 8 is the vestibulocochlear nerve. 9 is the glossopharyngeal. Here we don't have it, but 10 is the vagus. 11 is the accessory, which does shoulder shrugging, the traps. And 12 is the hypoglossal nerve, which does the tongue movements. You can check that for any fasciculations as well. So we asked the question, what cranial nerves control eye movement? So cranial nerve 3 opens the eyelid, the oculomotor, but cranial nerve 7 closes the eyelid. Damage of the cranial nerve 3 causes ptosis. So if we have damage to the cranial 3 causing ptosis, the eye's going to be basically stooped shut. However, if we have damage to the cranial nerve 7 that closes it, like in Bell's palsy, the eye's going to be stuck open. So based on if it's stuck shut, it's going to be a ptosis, and that's cranial 3 palsy. But if it's going to be stuck open, that's cranial nerve 7. Cranial nerve 2 is the afferent sensory pathway for the pupillary reflex. So cranial nerve 2, the optic nerve, takes in the light, and then cranial nerve 3 actually closes the pupil in response to that light. So cranial nerve 3, oculomotor, closes the pupil in response to the light that's detected by cranial nerve 2, the optic nerve. In cranial nerve 5 is sensation to the cornea. In cranial nerve 7 is the efferent portion. So like we already said, closing it is cranial nerve 7 when it closes it. In cranial nerve 5 is that sensation to the cornea. So when you do that wisp, you do that cotton wisp to the eye, that's actually cranial nerve 5, the ophthalmic branch of cranial nerve 5, sensing that, and then again cranial nerve 7 closing the eyelid for that. Okay, what does C5 do for reflex? What does C7 do? And what does C6 do? So what does C5, C6, and C7 do for their reflexes? So you can pause that and figure out what does C5 do, what does C6 do, and what does C7 do. So C5, it does the biceps and the shoulder, the deltoid there, and also the biceps reflex. So sensation to those areas and also the biceps reflex. C6 is the brachioradialis and the brachioradialis reflex. So in the middle of the forearm there, and also the brachioradialis flexes the elbow. And C7 is the triceps reflex, and it also does triceps extension. So C7 is the triceps, C6 brachioradialis, C5 biceps and shoulder. What nerve is injured in foot drop? So what nerve is injured in foot drop? What distribution is injured in loss of plantar or the Achilles reflex? So same thing, plantar and Achilles reflex. What's lost in that? What is lost in the patellar or knee jerk reflex? So same thing, patellar or knee jerk reflex. What nerve is lost in that? And another one, sensation to the lateral foot is gone. What nerve root is this? So lateral foot is gone. What nerve root is this? So foot drop, that's going to be the peroneal nerve there on the side, which extends the foot as well and also leads to that foot drop, or rather everts the foot. S1 is going to be injured in plantar or Achilles reflex. S1, that dorsiflexion reflex. L4 is going to be the patellar knee jerk reflex. And S1 is going to be the loss of sensation to the side of the foot there. What is the most common overall type of headaches? Type of primary headache. What is the overall most common type of primary headache? Where will you find tenderness in this type of headache? And what is the classic description of this headache? So most common type, where is the tenderness, what is it called in the vignette? So that's going to be, of course, a tension headache. The occipital region and upper traps is where they'll be tender. And they'll describe it as a band-like bilateral pressing, non-throbbing, whereas a different type of headache would be throbbing, that we'll get to, steady or aching. So especially a band or vice-like bilateral pressing, and that's a tension headache. Okay, next one. A 45-year-old woman has had recurrent, lancinating, brief episodic, stabbing, shock-like pain around her cheek and jaw. She complains it is very disabling and can be triggered by even brushing her teeth at times. What is her diagnosis? How does this condition arise? And what is the first-line treatment for this condition? So how does it arise? What's the etiology? And what is the first-line treatment? So that's going to be trigeminal neuralgia or tic douloureux. This arises due to compression of the cerebellar artery or vein and disrupts the trigeminal branches, all three, or typically the bottom two, so the maxillary and the mandibular branches, not as much the ophthalmic. And this lady had only the maxillary and mandibular. So the first line treatment for this condition is carbamazepine or oxcarbazepine. And you can do, if refractory to this, if the medication doesn't work, you can do the gamma knife surgery. So next one is a patient complaining of unilateral pulsating headache that is worse with light and sound. She states that her mom has had these before, and she states these have become debilitating with pain, and she needs to vomit as well often. She states visuals of geometric shapes often accompany the initiation of the headache. What is she dealing with? Visuals of geometric shapes. What % of these patients have a family history? And what is the first line if mild? What is the first line if a mild one of these? So of course that's going to be a migraine with aura, since she is having an aura. Most don't have an aura, however, and the percentage of family history is going to be 80% of these patients have a family history of migraines. For first line treatment, we just want to do NSAIDs and acetaminophen if mild, and put them in a dark room, in a quiet room, things like that. Next question. What is the physiology of our goal if it becomes moderate to severe? So what is the physiology of our goal? What agents can accomplish this? What are the contraindications? And what are the best prophylactic meds? So what's the physiology? What agents can we use? What are the contraindications? And what are the best prophylactic meds? So the physiology is that there's vasodilation. So there's vasodilation, so we want vasoconstriction. That's why a lot of headache meds, like Excedrin, I believe, have caffeine in it. So that helps vasoconstrict. Antiemetics as well. We should use antiemetics as well with these patients. And we should use triptans first line. So those are vasoconstrictors. Those work on serotonin as a mechanism of action. Then ergotamines. So ergotamines are less selective rather than triptans. So we want to use triptans first line and then ergotamines. Both are vasoconstrictors and they're contraindicated in pregnancy, stroke, uncontrolled hypertension, cardiovascular disease, and beta blockers or calcium channel blockers are the best for prophylaxis. And of course, these meds also block the pain pathways too. But we definitely want to vasoconstrict, first line triptans, second line ergotamines, and you can add an antiemetic on as well. Okay, so we kind of already added this. What is the mechanism of the antiemetics used in migraine treatment? What is the mechanism of action of antiemetics used in migraine treatment? What are the two biggest side effects we should know about? And what do we give to decrease the risk of this side effect? So this is a good one. What do we give to decrease the risk of this side effect? So dopamine receptor antagonists. So we're blocking dopamine. And remember, antiemetics, they work by inhibiting neurotransmitters. So like antihistamines, anti-dopaminergic, and so these anti-serotonin. So these are dopamine receptor antagonists that we're giving for antiemetics in this migraine treatment, such as metoclopramide, chlorpromazine, prochlorperazine as well. The biggest side effects are extrapyramidal symptoms and also QT prolongation. So we have to know that all these antiemetics cause QT prolongation, so we should check their QT beforehand, and also extrapyramidal symptoms. And we want to give Benadryl IV to balance out the loss of dopamine and loss of choline. So if these are inhibiting dopamine, remember the scale of dopamine and acetylcholine, so we want to lower that acetylcholine along with the dopamine. We don't want there to be an imbalance between acetylcholine and dopamine. So if we're going to inhibit dopamine to inhibit that nausea and vomiting as an antiemetic, we also want to take down some of the acetylcholine as well to bring both of them down at the same time. So that's why we give the IV Benadryl along with the antiemetics when we're treating a migraine. Next question is, what are your cardioselective beta blockers? So what are your cardioselective beta blockers? So a good mnemonic for that is BEAM, B-E-A-M. That's bisoprolol, esmolol, atenolol, and metoprolol. Next question is a vignette. So it's a 55-year-old male complaining of excruciating headache that is retroorbital, sharp, and lancinating. He reports it's worse when he tries to sleep, as well as after drinking alcohol. He states it comes in waves and lasts under 2 hours each time it occurs, so multiple times it's occurred. He has also noted some clear rhinorrhea, lacrimation, and nasal congestion. What is this? What is Horner syndrome? What is the first-line treatment for this? And how do we prophylax against this? So what is this condition? What is Horner syndrome? What's the first line? And how do we prophylax? So of course, this is a cluster headache. And in the vignette, we often see clues like 55-year-old male, way more common in males. So cluster headache, Horner syndrome is ptosis, meiosis, and anhidrosis. So this is ptosis, meiosis, and anhidrosis. The first line treatment, we need to hook them up to 100% O2, and that's on high flow nasal cannula, so like 6 to 12 liters nasal cannula, 100% oxygen, first line treatment. And prophylaxis, that's going to be verapamil for cluster headaches. Okay, next one is a 25-year-old obese woman that comes in with visual disturbance, nausea and vomiting, and the use of daily vitamin A. You find on her exam papilledema. What does she have? So interestingly, she takes vitamin A, you find papilledema, and she just has some general neurologic symptoms, and she happens to be a 25-year-old obese woman. What cranial nerve palsy might you find in this patient? What cranial nerve palsy? What is diagnostic and therapeutic for this patient? What is the first-line medical management? And what do we do if refractory to the treatment that we're trying, such as that diagnostic and therapeutic procedure? So that's going to be a pseudotumor cerebri, idiopathic intracranial hypertension. So remember, younger, middle-aged females, obesity is a risk factor, and you could find a cranial nerve 6 palsy, so that's the abducens nerve, and that's why they might be having some diplopia and could lead to that nausea and vomiting as well. So remember that abducts the eye to the outside in the lateral rectus muscle, so you could be having diplopia as well as general neurologic symptoms. And also, the headache gets worse with straining. Lumbar puncture is diagnostic and therapeutic because it's that elevated CSF. However, get a CT to rule out a mass effect first if you have those focal neurologic findings. You want to rule out mass effect, get a CT first. However, LP is diagnostic and therapeutic. And how do we diagnose it? Why is it diagnostic? Because this is an over 250 millimeter or 25 centimeters of oxygen. So the opening pressure is increased, basically, is indicative. So increased opening pressure, no other findings except general neurologic findings. Just an increased opening pressure, you want to be thinking pseudotumor cerebri or idiopathic intracranial hypertension. And the first line is acetazolamide. So we want to decrease that CSF production overall. And if that doesn't work, after some time of giving acetazolamide, we can do a ventriculoperitoneal shunt or an optic nerve sheath fenestration. So the fenestration basically makes cuts in the optic nerve to relieve some of the pressure around the eye. And ventriculoperitoneal shunt, just a continuous drainage, basically, from the ventricles into the peritoneum, where it just gets reabsorbed and distributed. So that's just a chronic treatment for refractory pseudotumor cerebri. And remember also, vitamin A is a risk factor. So the risk factors are vitamin A, young to middle-aged females, and obesity. Okay, so next we'll go over some CSF findings. So know these CSF findings. What would you find in multiple sclerosis? Can you name what you would find on CSF if you had a patient with multiple sclerosis? How about Guillain-Barré syndrome? What would you find in GBS on the CSF findings? Viral meningitis. What would you find in viral meningitis? What would you find in bacterial meningitis? A few things. What would you find in fungal meningitis? How about Pseudotumor Cerebri, like we just said? So what would you find in that? And what would you find in subarachnoid hemorrhage during an LP? So first one, MS, we're going to see illegal clonal bands of IgG. So MS, it's important to know illegal clonal bands, IgG. For Guillain-Barré syndrome, we're going to see that albuminocytologic dissociation. So it's just going to be basically elevated protein, but low white blood cells or normal white blood cells. So the only abnormality in GBS on LP is going to be that high protein. Next one, viral meningitis. So normal glucose in viral meningitis, because there's no bacteria there to eat up the glucose. So normal glucose, but it increased lymphocytes. So viral, we want to think lymphocytes. So anything viral, think lymphocytes. So viral meningitis, think increased lymphocytes. For bacterial, of course, decreased glucose. You must know that. Bacteria eating up the glucose. Increased white blood cells overall, as it's a bacterial infection, and increased protein from the metabolism of the bacteria itself. So increased protein, increased PMNs, and decreased glucose for bacterial meningitis. For fungal meningitis, similar to viral, where you have those increased lymphocytes. However, you know it's fungal because they have decreased glucose too. So fungus will eat up the glucose as well as the bacteria. So the two things that lower glucose, fungal and bacteria. However, in fungal, we have those increased lymphocytes instead. And pseudotumor, like we just said, we're just going to have an increased CSF pressure, but otherwise normal. So it's just that increased CSF pressure, which we'll see conditions later that don't have an increased CSF pressure. So it's important to know for pseudotumor, increased CSF pressure, it mimics a tumor. And of course, subarachnoid hemorrhage, we're going to see that xanthochromia, which is blood in the CSF. So it might be yellow or kind of a darker tan color, xanthochromia. So xanthochromia, blood in the CSF in subarachnoid hemorrhage. So next one is a vignette. Patient comes in with headache, stiffness, photosensitivity, fever, chills, and nausea and vomiting. What is your immediate thought? So that should be an easy one. Patient comes in with headache, stiffness, photosensitivity, fever, chills, nausea, vomiting. What is your immediate thought? Could be anything, but what is your immediate thought? What if they're a neonate? So now this patient is a neonate. Then what are you thinking of as the cause? What if they were a male with a rash at age 15? Then what would you be thinking of as the cause? What if they're a 65-year-old diabetic that was eating a lot of cheese? What would you be thinking of as the cause? And what is the most common overall bacteria in this group, which gives it away, especially 3 months to 10 years old? So neonate, what's the most common? Young male with a rash, what's the most common? 65-year-old diabetic eating a lot of cheese, what would you think of? And the most common bacteria overall, especially 3 months to 10 years. So a lot to take in there. So meningitis, of course. And for neonate, you're going to be thinking of group B strep. Group B strep, it could also be stuff like Listeria as well as E. coli. But group B strep is the one you want to be thinking of for neonate. Young male with a rash at age 15, you want to be thinking of Neisseria meningitidis. So Neisseria meningitidis is with a rash always at age 15. And 65-year-old diabetic eating a lot of cheese, so that could be Listeria monocytogenes. So Listeria monocytogenes, you want to be thinking of in any patient older than 50 or under 3 months. So older than 50, under 3 months, you want to be thinking of Listeria. And also eating some kind of unprocessed cheese is a risk factor. And the most common bug overall is going to be strep pneumo, so strep pneumonia. So what are the two classic physical exam maneuvers that would key you into this diagnosis? So we said meningitis was the first thing on our mind. What are the two classic physical exam maneuvers that you would do? So those are what are the two classic physical exam maneuvers. And also 25% of these patients overall have a history of what? So what do these patients typically have a history of? Well, in 25%. And what is the initial best test? Only if what, though? So that's a kind of broad question. What is the initial best test? Only if what? So, of course, the Kiernig sign and the Brudzinski sign. Kiernig's when they're lying on their back and they flex their hip and extend their knee. So Kiernig's, K for knee, extending their knee. Brudzinski's is when they flex their neck forward and they also then flex their hip. And these are both, you want to see them positive for bacterial meningitis. And 25% have a history of a recent URI, especially a otitis media or a sinusitis as well. So I guess that strep pneumo is the most common cause. So if it's strep pneumo from otitis media or sinusitis, it can kind of track all the way to the meninges, and 25% can get it from that. And what's the best initial test? It's typically CT if you have a focal neurofinding, or if they're immunocompromised, over 60, history of CNS pathology. Otherwise, you can just do the LP, which is the best. So you don't need the CT, but if they have those risk factors, you want to do the CT first to rule out a mass lesion. Because if you do the LP and they have a mass lesion, you could risk herniating the brain. So that mass could the increased pressure from the mass could herniate some of the brain through basically the foramen magnum in the base of the skull. So we don't want that to happen, obviously. So that's why we get a CT first if we have neurofindings, focal neurofindings. Otherwise, the LP is the best test, of course, and you'll see different types of findings depending on the pathology. Okay, so now treatment. So a lot for meningitis to know. So we have to know the treatments. What is the treatment of a patient that's 3 months to 50 years old? So we said that's a critical age there, 3 months to 50 years old. What's going to be our antibiotic treatment? How about 3 months? How about before 3 months and after 50 years old? So before 3 months and after 50 years old, what would you be doing for treatment? How about treatment in neonates? What would you do for treatment in neonates? And what add-on to your treatment decreases residual cranial nerve palsies and reduces mortality? So what add-on? We give this all the time in URIs and lung problems. So what add-on would you do? And what two agents can be used in post-exposure prophylaxis? So post-exposure prophylaxis. So a lot of questions here. Again, one more time really quickly. 3 months to 50, what antibiotics you're going to use? Before 3 months and after 50, what are you going to use? What do you want to cover for? How about for neonates? What do you want to add on in your treatment? And what two agents can be used in post-exposure prophylaxis to meningitis? Okay, so vanc and ceftriaxone, if they're those middle age, 3 months to 50 years, you can just do vanc and ceftriaxone. Remember ceftriaxone with the great gram-negative coverage as well as CNS penetration. So ceftriaxone gets in there pretty good, as well as vanc. So vanc for that gram-positive coverage. So VCA is how I remember it for under 3 months and over 50. So again, vanc, ceftriaxone, but we can add ampicillin, and the reason for that is listeria. So we want to cover Listeria monocytogenes, and we can cover that by adding ampicillin to these patients. Similarly, in neonates, we do the ampicillin, but we add gentamicin instead. So for neonates, to cover that GBS, we can add ampicillin and gentamicin. So ampicillin and gentamicin for neonates for that GBS. And we actually add, to decrease the mortality in cranial nerve palsies, the answer is going to be dexamethasone. So we want to add dexamethasone, a steroid, of course, to this antibiotic regimen. And post-exposure prophylaxis is going to be Cipro or rifampin, except you only need to do this if they're close contacts or prolonged exposure. So close contacts and prolonged exposure, Cipro or rifampin. Okay, next one. A patient comes into the clinic and complains of mental fog, a wobbly gait as if the feet are stuck to the floor like a magnet, and also urinary incontinence. When you do his LP, you find the opening pressure is normal. It's 5 to 20 centimeters of H2O. And remember, we said over 25 is abnormal. What's his diagnosis? So again, mental fog, a wobbly gait, like his feet are stuck to the floor like a magnet, and also urinary incontinence. So he has this triad of things going on. He has a normal opening pressure, however. What will you see on his MRI? So what will you see on his MRI, and what is the first-line treatment for this patient? So this is, of course, normal pressure hydrocephalus. So he had a normal pressure. This is normal pressure hydrocephalus. This is basically failure of the CSF reabsorption, usually due to another preceding condition, and this is typically chronic. So failure of CSF reabsorption, so it continues to accumulate. And you'll see, of course, the ventricles are enlarged then. However, there's a normal pressure. So I don't know how there can be a normal pressure if the ventricles are getting bulged and enlarged, but nonetheless, we do have a normal pressure, which is different from the idiopathic intracranial hypertension, pseudotumor. So the ventricles are going to be bulged if you get an MRI, and there'll be normal pressure, however. If you do an LP, it might be therapeutic as well, taking off some of that fluid. And remember, so CUA is the triad I remember for this. CUA, cognition, urinary incontinence, and ataxia. And it's typically, they have a wobbly gait with their feet glued to the floor like a magnet. So that's the quote-unquote thing to alert you to that. So CUA is how I remember that. And the treatment is a ventricular peritoneal shunt. So like we said in idiopathic intracranial hypertension, that was a refractory treatment, as well as the optic nerve sheath fenestration. But for here, this is the go-to treatment. So this is the first line, whereas the first line in that was acetazolamide. So here, you just want to, in normal pressure hydrocephalus, you just want to go right to that VPS. Okay, next one is, what is the most common cause of viral meningitis? So what's the most common cause of viral meningitis? How about the most common cause of aseptic meningitis? And which has focal findings and which does not? Okay, so which has focal findings, aseptic or viral meningitis, and what's the most common cause of each? So important to know. So aseptic is just going to be enteroviruses like echovirus or Coxsackie virus. So that's aseptic. So although these are viruses, you want to be sure that you know that for viral, herpes is the #1 cause. So herpes has a high mortality rate, and it's the #1 cause of viral meningitis. But aseptic is going to be those other viruses. So virus are going to have focal findings, and along with personality changes and altered mental status, which is how you differentiate it from viral. So remember those personality changes, altered mental status, a little bit different from regular meningitis. So that's what you want to think of in viral meningitis, are those personality changes and altered mental status. And of course, you want to do IV acyclovir as well. Where does the pyramidal desiccation happen? So where does the pyramidal desiccation happen? What part of the brain does it happen? Do those fibers cross over? And what does the dorsal column transmit up the spinal cord? So what does the dorsal column do basically up the spinal cord? How about the spinothalamic tract on the lateral sides? What does that do? So the spinothalamic tract, the dorsal column, and where does the pyramidal decussation happen? So the decussation happens in the medulla. That's the crossing of the fibers, like we said. So it crosses over at the medulla. And that's why in a stroke, if we have a stroke on one side, we're going to get those opposite side fibers, like make it run down to like the foot in the opposite side. So right-sided to left-sided. And so the dorsal column does sensation to fine touch as well as proprioception. And the spinothalamic tract does pain and temperature. So pain and temperature for the spinothalamic tract. So we'll pause there and then we'll continue along in the next video.